Good evening and welcome health professionals across Australia to the 2021 Immunisation Coalition Meningococcal webinar. My name's Susie Blackburn. I run the information and events with the Coalition, and I welcome you to the first of our 2021 series that includes 5 diseases that we'll be looking at over the remainder of the year. What we might do before we begin is actually look at a little bit of housekeeping before we introduce our speakers. So we might pop forward in the slides. While we're sorting that out, you may be aware that the Q&A is the box to open up and pop your questions in for this evening's activity. You can pop some details in the chat if you're having any technical difficulties, and we'll try and sort that out for you as well. If you attend for 50 minutes of tonight's webinar, you will receive an attendance certificate that you can use for your professional development if it is appropriate. The webinar this evening will be recorded, so we'll have our participants or attendees on mute, and then we will record it and edit it ready for the website, which will go up at the end of next week or into the following as soon as we can, basically. All right, so I might start off with a poll to find out what our attendee population is, where you're all coming from tonight. So if you wouldn't mind approaching your screen and just indicate which profession or expertise area most closely represents your background. I'll leave you a few seconds. All right, most of us have voted now, so I might just show you. As you can see, we've got mostly nurse midwife background, a couple of GPs, researchers, pharmacists, and a few others. Thanks very much for joining us tonight. All right, well, enough of me. What I'd like to do now is please introduce Angela and Jenny. We are really lucky at the Coalition to have fantastic members. Angela and Jenny are 2 of those people. Just a bit of background. Angela is an immunisation education consultant based in South Australia and a member, as I said. She's been involved in immunisation program delivery for over 20 years, originally as an immunisation provider and program coordinator. She has roles within the Division of General Practice, South Australia Health Immunisation Section and Medicare Local Network, and is presently with the Primary Health Network. With her tonight, we have Jenny Brown. Jenny's had 38 years of experience practicing as a registered nurse, midwife, child and family health nurse. She's a certified lactation consultant and an immunisation provider. Her specialist areas include women's, children and family health, and she's passionate about supporting families to make informed choices, and that's why we're here. So without further ado, I believe Jenny is going to begin tonight's presentation, so I will hand over to you. Thanks, Jenny. Sorry, Jenny, we might just have you on mute. We're having some sound issues. We can see you and hear you. Off you go. Thank you.
You can hear me?
That's correct.
Okay. Thank you, Susie, and welcome to all registrants. Over the next hour or so, Angela and I will endeavour to provide you with an overview of the meningococcal disease and an update on current statistics and vaccine recommendations. We're excited to share this information with you and hope that by the end of the webinar, you'll all have an increased understanding of the disease and the vaccine recommendations. So meningococcal disease refers to an illness caused by the bacteria called Neisseria meningitidis, also known as meningococcal. Neisseria meningitidis is an organism of humans and who are the only natural host. The bacteria normally colonises in the mucosa of the upper respiratory tract without causing disease. Sometimes bacteria invades the body and causes certain illnesses which are known as meningococcal disease. Meningococcal is rare, but is often severe and can be deadly, including infections of the lining of the brain and spinal cord, known as meningitis, and the bloodstream infections, which are bacteremia or septicemia, with symptoms appearing suddenly. The most common causative serogroups are A, B, C, W, and Y, with the main type seen in Australia as meningococcal B, W, and Y. Since the introduction of the A, C, W, and Y vaccination programs, the incidence of meningococcal W disease has reduced, and the overall rate of invasive meningococcal disease has fallen to 0.8% per 100,000, beg pardon, in 2019. Currently, Men B and Men W account for similar amounts of the disease and cause the majority of invasive meningococcal disease within Australia. The burden of invasive meningococcal disease due to Men W and Men B is disproportionately higher in the Aboriginal and Torres Strait Islander people, particularly in those aged under 15 years. Neisseria meningitidis is a fastidious bacterium, dying within hours on inanimate or non-living surfaces, and can be either encapsulated or not, and described as kidney or coffee bean shaped. However, Neisseria meningitidis strains causing invasive disease and isolated from sterile sites such as the blood or the cerebrospinal fluid are almost always encapsulated. Serotypes are distinguished by differences in surfaces, in surface polysaccharides or outer membrane capsule. The capsule is essential for the survival of the organism in the blood, as it provides resistance to the antibody complement mediated killing and inhibits phagocytosis. Meningococcal disease can occur throughout the year, but is most common in the winter and spring. Cause of disease. In 2020, the data was 90 cases of invasive meningococcal disease were reported to the National Notifiable Disease Surveillance System. Between 2016 to 2019, overall invasive meningococcal disease numbers varied between 207 and 380, which signifies quite a marked decrease. 2021 data to date, and this was in February, earlier February that I looked at it, equaled 6 cases. Meningococcal serotype C, or Men-C disease, has decreased markedly after the implementation of the National Men-C Conjugate Vaccination Program in 2003, with the number of cases falling from 225 in 2002 to 14, which is 3.8% of cases with an identified serogroup in 2017. Serogroup A disease remains rare in Australia. How is meningococcal disease spread? As already mentioned, meningococci are carried and transmitted only by humans. Between 5 to 25% of people carry meningococcal bacteria at the back of their the back of their nose and their throat without showing any illness or symptoms, and this is called being a carrier. The mean duration of carriage in settings where prevalence is stable has been estimated at about 21 months. The carriage rates vary from around 3 to 25% of the population, depending primarily on age, with peak carriage rates occurring in adolescents. So greater than 20% of adolescents may be carrying the bacteria. Smokers have an increased carriage rate, which may increase transmission and their risk of invasive disease. Individuals who become asymptomatic carriers of meningococci are very unlikely to develop invasive meningococcal disease, but for some individuals, it can be an invasive disease. People spread meningococcal bacteria to other people by sharing respiratory and throat secretions, so saliva or spit. Generally, it takes close or lengthy contact to spread these bacteria, and for example, coughing or kissing. The bacteria can only live outside of the body for a few seconds, so you can't catch meningococcal from a casual contact or from the environment. The bacteria do not spread easily by sharing food or drinks, although the survivability of meningococcal on glass for 4 hours in ambient temperature has been shown. Fortunately, they are not as contagious as pathogens that cause the common cold or the flu. And people do not catch meningococcal disease through casual contact or by breathing air where someone with meningococcal disease has been. Transmission from a symptomatic case is uncommon. The vast majority of cases are sporadic, with transmission assumed to have occurred from prolonged close contact with an asymptomatic carrier in the network of close contacts. So symptoms of meningococcal disease, meningitis and septicemia. Invasive meningococcal disease, as stated earlier, meningococcal disease has two main clinical presentations, meningitis and sepsis, which often occur together. Sepsis is more common and more dangerous. It's more likely to be fatal when it occurs without meningitis. When someone has meningococcal septicemia, the bacteria enter the bloodstream and multiply, damaging the walls of the blood vessels. This causes bleeding into the skin and organs. Both of these types of infections are very serious and can be deadly in a matter of hours. The rate at which the disease develops varies between patients. Those with more severe and sudden onset will be critically ill within the first 24 hours. Leaving a very narrow window of opportunity to deliver life-saving treatment. With an overall mortality rate of around 8%, or 8 to 10%, the majority of deaths occur in the first 24 hours. Although the majority of victims will recover fully, 8 to 10% of those infected will die, and around 20% will have permanent disabilities, ranging from learning difficulties, sight and hearing problems, to liver and kidney failure, loss of fingers, toes and limbs, and scarring caused by skin grafts. Symptoms. So the symptoms often present in a non-specific manner with fever, lethargy, reduced feeding, headache, nausea and vomiting, cold or discolored extremities, arthralgia and myalgia. Incubation period is approximately 3 to 4 days, but it can vary from 1 to 7 days and rarely up to 10 days. The person is infectious as long as the meningococcal bacteria are present in the nose and the throat, and the bacteria disappear within 24 hours of starting an appropriate antibiotic treatment. These symptoms are similar to those caused by non-threatening viruses, making a confident diagnosis in these early stages really quite difficult. Approximately 95 to 99% of children with fever and petechiae will have a cause other than meningococcal infection. So you need to be highly suspicious and reassess, ideally by the same doctor within 4 to 6 hours if appropriate, and advise carers and family members to seek further medical assistance if patient deteriorates or they are worried. All patients with suspected meningococcal infection should have blood collected as soon as possible for culture, PCR testing, C-reactive protein, and full blood count. Where appropriate, a sample of cerebral spinal fluid should be collected for PCR, microscopy, and culture. Blood or cerebral spinal fluid is how a conclusive diagnosis is made. So continuing on with symptoms, you can see a list of symptoms on the screen there for septicemia and meningitis. Some of them cross over, And in respect to meningitis, there are some that aren't present. But some or all of these may not, symptoms may be present, and an initial presentation may appear like a typical cold or flu symptoms, gastroenteritis, or even a hangover, a severe headache, fever, sore throat, or lack of energy. Alternatively, it could start as a sore arm or leg, an aching joint, or pains in the chest or stomach, depending on whether the illness starts off as meningitis or septicemia. Symptoms in older children and adults include headache, fever, vomiting, neck stiffness, and joint pains, light sensitivity, drowsiness, and confusion. Rash. This happens when the bacteria multiply in the blood vessels and release toxins, which in turn damage the blood vessels, so the blood leaks through the tissues underneath the skin. The rash may start with a simple spot or blister anywhere on the body, then may progress to red pinpricks like small mosquito bites, and spread quickly into purple bruise-like blotches or hemorrhages which cover the body. In this final critical stage, the person can go into shock, their blood pressure falls, and the circulation fails in the body extremities, the fingers, toes, and limbs. And this is where amputations or death may be a result. Therefore, it's important not to wait until a rash appears before seeking treatment, as the meningococcal rash signifies a critical stage of the disease. The rash can be more difficult to see on dark skin and may be visible in the paler areas, especially the soles of the feet, palms of the hands, the abdomen or the conjunctiva, or the palate. Important to perform a full body check if a person is symptomatic. So we have a poll now that you can vote on, and the question is a rash always present in people with meningococcal disease? A, no. B, yes. C, if it's going to appear, it will appear early in the disease. We'll just wait for the answers to come through.
Thanks, Jenny. It looks like we've got about 50% of our audience has voted. We'll give them a few more seconds. Okay, I will share, ending the poll. Here's the results.
Okay, so it looks like about 77% of participants answered A, which is correct. So, yep, I think that's correct, wasn't it, Susie? Yep. So basically, A is correct. No, the rash does not always need to be present. And in fact, you don't wait for a rash to appear. As mentioned, this can be a later symptom and quite diabolical. It may not appear at all. So don't assume if there's no rash, there's no urgency, and don't let doctors or hospital staff assume that either. You know, if you're concerned, you need to stress that.
Thanks, Jenny, for confirming that was correct.
Now, symptoms in babies. So babies often don't have the many classical symptoms. So, and they can have different symptoms to older children or adults. So newborns and babies may not have, or it may be difficult to notice the classical symptoms. Instead, they may be slow or inactive, irritable, vomiting, feeding poorly, or have a bulging of the soft spot, so the fontanelle, the anterior fontanelle on the top of their skull may be bulging. So, and in young children, doctors may also look at the child's reflexes for signs of meningitis. But once again, it looks like any other type of illness, so it can be easily misdiagnosed, and consider the level of parental concern. So particularly compared with previous illnesses, and the perceptions of parents and patients should always be taken seriously. advise parents of the signs and symptoms of meningococcal disease, and check the baby regularly for deterioration or the appearance of a rash. And encourage parents to be diligent and return or get a second opinion if they're worried and or concerned, or if the child worsens at all. Really important. Complications, and as you can see from the slide, there's many devastating complications that can arise from invasive meningococcal disease, and some of them we have mentioned already. So this slide just is a schematic of sepsis, so also known as septicemia or blood poisoning, and the schematic just shows the cycle of sepsis, which you can see leads to tissue damage, multiple organ failure, and then can lead to death. So for adults who survive sepsis, half will be left with a permanent disability and or impaired function. For example, insomnia, difficulty of getting to sleep or staying asleep, nightmares, vivid hallucinations, panic attacks, disabling muscle and joint pains, decreased mental cognitive functioning, loss of self-esteem and self-belief, and as previously mentioned, organ dysfunction, kidney failure, respiratory problems, and amputations. So many people who do survive severe sepsis recover completely and their lives return to normal. But some people, especially those with pre-existing chronic conditions, may have permanent organ damage. For example, in someone who already has impaired kidneys, sepsis can lead to kidney failure that requires lifelong dialysis. There is also some evidence that severe sepsis disrupts the person's immune system, making him or her more risk to infections. Studies have shown that people who have experienced sepsis have a higher risk of various medical conditions and death, and even that can occur even several years after the episode of meningococcal disease. Who is most affected? The most affected are the saliva sharing age groups. However, contact with saliva from the front of the mouth, for example, from sharing drinks or cigarettes, has not been shown to be a cause of meningococcal disease. We must remember that disease is reported across all age groups. And according to the NCIRS meningococcal vaccine fact sheet, most meningococcal disease occurs in children aged under 2 years of age and in older adolescents and young adults aged 15 to 24 years. Meningococcal B still remains the major cause of invasive meningococcal disease in children aged under 2, particularly infants aged under 1 year, adolescents and young adults. And both men W and men B disease have peaks in the under 2 and 15 to 19-year-old groups. However, a larger proportion of men W cases occur in the adults aged equal to or greater 45 years, and medium age being around 44 years compared to men B cases. Men W disease appears to have a higher case fatality rate than men B disease, with about 9.3% for meningococcal W versus about 5% for meningococcal B. This may indicate a tendency of men W disease to cause more severe infection. The burden of invasive meningococcal disease due to men W and men B is disproportionately higher in the Aboriginal and Torres Strait Islander people, particularly in those aged under 15 years. And the risk factors, so you can see a list of risk factors there, and so people who are immunocompromised due to certain conditions, including inherited defects of deficiency of prevalent or complement components, current or future treatment with, now I'll try my best to say this, eculizumab, functional or anatomical asplenia, and after hematopoietic stem cell transplantation or HIV infection, have an increased risk of acquiring invasive meningococcal disease. And this is where MenACWY and MenB vaccines are funded for this population. Children and adults with a functioning spleen are increased, children or adults without a functioning spleen are at increased risk of infection with encapsulated bacteria, most importantly Streptococcus pneumococcus, infections with other bacteria such as Neisseria meningitidis and Haemophilus influenza type B also occur at an increased rate in such patients. So just some information in relation to the eculizumab, which is also known, I think the brand name is Soliris or Soliris. Soliris, yeah. Now this is a very expensive drug that it's usually prescribed by nephrologists, and it's a drug that, due to its mechanism of action, increases the patient's susceptibility to meningococcal infection. And it's usually used for patients with paroxysmal nocturnal hemoglobinuria or PNH. So, which leads to a generation of population of abnormal red blood cells. So these patients need to be vaccinated with the meningococcal vaccines prior to or at any time of initiating the Soliris drug, and revaccinate according to the current medical guidelines for vaccine use. So patients who initiate Soliris treatment less than 2 weeks after receiving a meningococcal vaccine must receive treatment with an appropriate prophylactic antibiotics until 2 weeks after vaccination. And these patients need to be monitored for early signs of meningococcal infections and evaluate immediately if infection is suspected and treat with antibiotics if necessary. So continuing on with risk factors. So as you can see on the slide, having a chronic disease, smokers, current or exposure to smoke, so secondhand passive smokers, being a current smoker, attending school or university, intimate kissing. So consider vaccination for your patients with risk factors, but you also have to keep in mind that not all may be under the National Immunisation Program. And other risk factors include occupational exposure, for example, meningococci in microbiological laboratories, crowded living conditions, intimate kissing with multiple partners, and recent or current viral infection of the upper respiratory tract. And as I mentioned, cigarette smoking, passive or active, appears to have an increased risk of a person developing meningococcal disease. And burden of the disease. So meningococcal disease notification rates between 2002 and 2013 was, had a peak of around 3.5 cases per 100,000 in 2002 to 0.6 per 100,000 in 2013. So you can see that there was quite a marked decline. Then it actually increased in 2017 from reaching 1.5 cases per 100,000 people. Since the introduction of meningococcal ACWY vaccination programs, the incidence of MenW reduced and the overall rate of invasive meningococcal disease fell to 0.8% per 100,000 in 2019. When is it most prevalent? If you can see that, and the graph can be sort of challenging to read because it's quite busy, but it's noted that it has a seasonal trend. So meningococcal disease is most prevalent between the months of June and September, so our winter months. And as you can see from that slide as well, that there was quite a peak in numbers in 2017. And notification rates for invasive meningococcal disease by serogroup between 2002 and 2019. So in 2019, meningococcal B accounted for 50% of all invasive meningococcal disease in Australia. So New South Wales reported the largest number of notifications of meningococcal B, invasive meningococcal disease. The number was 34, which accounted for 59% of invasive meningococcal diseases within the state. So 34%, 34 out of the 58 were meningococcal B, and that was in 2019. But South Australia was again the state with the highest proportion of meningococcal B, with 72% of the statewide invasive meningococcal disease cases being men B. So they had 25 invasive meningococcal disease cases in 2019, and 18 of those were meningococcal B. So deaths in Australia between 2015 and 2019, they are beginning to decline, and you can see the numbers up there. And in 2017, you can see the numbers were quite high, but as we've already stated, there was a peak in overall invasive meningococcal disease in 2017, so that would no doubt account for that. And where is it most prevalent? So this just gives you an idea of the different serotypes, the numbers in each state, and the overall numbers, and the percentages per 100,000 population.
And Jenny, I see we are coming to the 2020 numbers as well shortly. I've just got a question from Dell that I'm hoping will be answered about possibly being less cases in the last 12 months.
Okay, thank you. So these are the 2020. So you can see that there's been 90 cases. So for 2020, Australia-wide. The previous slide, if I go back, the overall cases, oops, sorry, previous, it's only showing 6 months worth from what I can see there. So 1st of January to the 30th of June. So it's not a full 12 months. Can you explain that any further, Angela? I'm just going to refer to Angela, sorry, who's sitting beside me. So it's 6 months worth of data there for 2019. So no doubt that the numbers were probably at least double or more than that. And when we go to the next slide, you can see an overall amount of numbers for 2020 were 90. So I hope that makes sense.
That's great, thank you. And do we know out of that 90 cases how many were deaths by chance?
No, sorry.
Not for 2020.
Sorry, I didn't mean to put you on the spot there.
No, that's okay.
We'll try and add that to some information on our website shortly.
Yeah, and perhaps that's something that we can try and follow up. There's a lot of statistics out there, and they're not always the easiest to find, and there's that many different types of stats that I'm not overly au fait. Angela's probably much more skilled at trying to find them than me. But if there's a specific question around stats that we haven't presented tonight, it's something that we can try and find.
Thank you. And they can email us at immunisation.
Yeah.
For that.
Yeah.
Thanks very much.
No problem. Okay. So national notifications for serogroups B, C, Y and W for 2019. Invasive meningococcal disease caused by MenW was seen in all age groups in 2019, except those aged between 10 to 14 years. And for those aged less than 5 years, the number and the proportion of invasive meningococcal disease cases caused by MenW were only about 12 cases, so about 24%, and was lower than that reported in 2018. For those aged over 65 years, MenW was the predominant cause of invasive meningococcal disease. Men-Y, invasive meningococcal disease, was reported in all age groups in 2019, except in those aged between 1 to 9 years and 25 to 44 years, with the highest number and proportion seen in those aged around 45 or more years. So I hope that makes sense. Okay, so that's sort of meaning that out of, I might get you to help me with this, Angela. So just out of 68 of the total invasive meningococcal disease notifications, 25 were attributed to the Men-Y. Okay. All right. So now I've finished my section, and I'm going to hand you over to Angela, who's going to continue on with the remainder of the webinar and talk to you about prevention vaccines. Okay, thank you.
Thanks, Jenny, and welcome to you, Angela.
Oh, it's like a little hot chair, isn't it? Yeah. Jumpity jump. Welcome, everyone. Nice to see you, kind of, all on board tonight. And it was good information that Jenny has presented. I'll just follow on with the prevention side of things and just a little bit more about program type things. I am going to, just on this slide, sincerely apologise for my dyslexia. Trumemba is meant to be spelt a little bit different. So Trumenba is how it should be spelt. So I will make sure that that slide's corrected. But so sorry about that. So there are different types of meningococcal vaccines that are registered here in Australia. Obviously, we're not using Meningitis anymore, which was the combination Men-C and HIV vaccine. We can still get meningococcal C vaccine to use in our adolescent catch-up programs. Otherwise, we are generally using the meningococcal ACWY vaccines, as well as Vaccination is also on the funded program. Trumemba is available for people over 10 years of age, but it's not on the funded program at all. So we'll just do a really quick poll here. So in regards to those meningococcal vaccines, how are Menveo and Nimenrix vaccines administered to the patient? Are they in liquid form and simply just drawn up and given by IM, or do they consist of a powder and a liquid that need to be reconstituted, or is it oral, or are they best administered just 2 months after other vaccines have been given? We'll just give you a little minute.
Thanks, Angela. We've got about 45% have voted, so we'll give a few more seconds.
Sure.
split evenly between two, which is interesting. So I'll give them a few last seconds. Pop your answers in there. Okay, here are your results.
Okay, interesting. Okay, so the answer just slightly ahead at 57% is actually answer B. It does consist of a powder. So there's a lyophilized powder in a vial. It accompanies with a syringe that contains the meningococcal C, W and Y component. So your lyophilized powder component is your meningococcal A component. So you do need to reconstitute those. So well done, very good. So who should we be giving these vaccines to is the next question. So we've already discussed that there's certain age groups that are at increased risk of invasive meningococcal disease. And of course, these are the age groups that we would be targeting for the quadrivalent meningococcal conjugate vaccines. But of course, some will get it as funded vaccines, other will get it as a recommended vaccine. And I'm not sure what you do in your particular practices around recommended vaccines and whether or not you do have those conversations with your patients when they do arrive, what vaccines are actually recommended for them, rather than just having conversations about what vaccines are funded for them. So we definitely want to make sure that every person is spoken to about recommended vaccines, and that includes the meningococcal vaccines. And as Jenny highlighted, meningococcal disease affects all age groups, but not all age groups are eligible for NIP funded vaccine. So super, super important that you do have those conversations with every patient that you see. So another poll, we have a 5-year-old child that presents for catch-up vaccination, and you note that the child received a dose of Meningococcal vaccine when they were 12 months old. Would you offer a dose of meningococcal ACWY? Remember, Meningococcal was a Hib and meningococcal C vaccine combination. So would you offer meningococcal ACWY? Yes, because it's funded, or no, because it's not funded, or yes, but on a private prescription.
Very good. We've made it to about 60% voted, so we'll give them 5 seconds or so.
Well done, hot fingers.
It's a good question though. They're thinking about it, Angela. Just a moment. There we go.
Okay, that's very interesting. Okay. All right, so according to the ATAGI, or Australian Technical Advisory Group on Immunisation, on the meningococcal statement, there is no catch-up program really for meningococcal ACWY if a child received meningococcal C vaccine at 12 months of age. So for this particular scenario, this child did receive a meningococcal C combined vaccine at 12 months of age. So we would, yes, certainly be having the conversation with the parent to say that the child has got some protection on board for meningococcal C serotype, but not for A, W and Y. However, we now have a 4-strain vaccine available, but it would be on private prescription for this particular child. It is quite likely that once this child gets into the high school program, potentially they may be offered a meningococcal ACWY, which is what's currently happening at the moment.
This might be a good opportunity to ask you about some prices if you know them.
Okay.
Somebody asked.
All right, prices.
Ish.
They can be quite varied. You can get something probably for around about $45 up to $90. I would always recommend that people let their fingers do the walking and they phone around at around 5, 6 different pharmacies. Pharmacies don't really have any marking up limitations. So there will be, if you phone 5 or 6 pharmacies, you'll get 5 or 6 different prices. Go with whoever's the cheapest. It's the same vaccine. The other thing to remember is if people have private health insurance, then to have a quick chat with their private health insurance company to see what kind of a rebate that they would get on a private prescription vaccine. And most private health companies do rebate a portion back off a private prescription for a vaccine. So that's the other way, potentially, that they could get a bit of a cheaper vaccine.
Okay, and finally, related to that, are any of these vaccines funded for hematopoietic, is it, stem cell transplants by any chance?
Hematopoietic stem cell transplants, you did exceptionally well. So can I just take that one on notice, because I will just scroll through and find the latest ATAGI advice on that one. All right.
No problem.
In regards to the special risk groups. All right. And we will find those very soon.
No problem. And someone's just commented that Bexsero is about 110 to 120, they think.
Yeah, okay. Yes, your Bexseros. And so your meningococcal B vaccines are a little bit more expensive than your meningococcal ACWIs, most definitely. So probably the cheapest that you'll find a Bexsero vaccine is around about that $120 mark. But and I understand that Tremember's at a similar price.
Okay, I'll let you move on. Thank you.
Okay, no worries. So and we'll just track down that ATAGI advice in regards to hematopoietic stem cell transplant. Okay, so who should be receiving this meningococcal ACWI vaccine? Obviously, Nimenrix is the meningococcal ACWI that's funded on the national program. We're giving it to children at 12 months of age. It's a single dose. If babies start their program a little bit earlier, then there's certainly a change in the number of doses that are needed. There's also a high school program, so generally delivered in year 10. So just make sure that those adolescents are actually receiving their vaccines in the school program. General practice certainly can administer school program vaccines to these kids that perhaps don't wish to be vaccinated at school or may have been absent from school on the day that the nurses came to do the program. So definitely catch them up. Make sure that you always ask the question whenever you see individuals coming in. Remember the halo, health, age, lifestyle, occupation. If you see someone at the age group that potentially should be getting vaccines, just always raise it as a bit of a question. What year level are you in? Oh, year 10, so have you lined up for your meningococcal vaccine yet, etc., and have a bit of a conversation about that. And just double check the AIR to see whether or not they have actually received the vaccine.
And Angela, Tanya's asked if the ACWI vaccine has been given at 11, 12 years of age, what would happen when they reach high school? Would they have it again in the schedule, or if it was received earlier?
There would be no recommendation. If somebody has paid on a private prescription, for example, for their 12 or 13-year-old to have ACWI, at this stage they wouldn't particularly need to line up in the school program in year 10.
Okay, great. Thanks for that.
A single dose. Okay. So Men B vaccines, that's a little bit of a different story. Obviously, we really need to target the very, very young children, particularly those less than 2 years of age, and particularly our adolescents, just exactly like Jenny was saying before, you know, those saliva sharing age groups. So we definitely want to offer the vaccines to above 6 weeks age if they wish to reduce the risk of meningococcal disease. We know that meningococcal disease risk is low. It is a rare disease that we're talking about, but it could be a really significant disease and exceptionally frightening disease because of how rapid people can deteriorate and become exceptionally unwell and potentially die. So just remember that there is availability on the private prescriptions, but there is also some funded programs in place. So, should pregnant women be immunised against meningococcal disease? So, yes, they should between 28 and 32 weeks of pregnancy, or yes, they should between 28 and 32 weeks receive the 4-valent meningococcal, or they should just have a meningococcal C between 28 and 32 weeks of pregnancy, or meningococcal vaccines really aren't usually recommended for pregnant women.
Okay, doing well. Looks like it's very different. People are pretty confident with this answer. Give them a few more minutes, seconds.
Excellent. No, just initial.
And here you go.
Oh, very good. Yes, you're super confident about that. Absolutely. So yeah, look, you know, pregnant women, generally it's not a recommended vaccine for them for sure. We'd be certainly concentrating on flu and DTPA for pregnant women, certainly, if, you know, particularly from the 20 weeks pregnant mark. So well done. Okay. So let's look at vaccine effectiveness. Now, you probably have heard lots and lots and lots of talk around vaccine efficacy and vaccine effectiveness, etc. They're two different things, although they're often interchanged. Certainly vaccine efficacy is something that is looked at during the clinical trial stage. We're looking at small numbers. When we're looking at vaccine effectiveness, we're actually looking at the whole world once the vaccine is released and there's lots and lots of people getting vaccinated. We can see how effective the vaccine is. And certainly with the 4-valent meningococcal C conjugate vaccines, certainly we're looking to see that 80 to 85% effectiveness. So we've got to be really transparent when we talk about these vaccines or any vaccines. There's really only a couple of vaccines where we could almost say they're 100% effective in 100% of people to protect people from disease. But we've got to be really careful when we talk to people about vaccine effectiveness and talk to them around the fact that, yes, you have received the vaccine and it will be effective in reducing the likelihood that you will contract this disease. And should you contract this disease, the vaccine will reduce the likelihood that you will become seriously unwell or potentially die from this disease. So we need to be really transparent with that type of information about all of the vaccines that we are offering. I alluded previously to the fact that we've been using Men C vaccine in Australia since 2003. Absolutely fantastic response. We very rarely see meningococcal C notifications coming now. Very, very low numbers indeed. So there is this evidence too of this indirect protective benefit or herd immunity, so which is absolutely fantastic to see. So we'll be keenly watching data for the quadrivalent ACWI vaccines as well. So MenB vaccine efficacy, so this is once again quite good protective antibodies against MenB strains. So we would highly recommend this vaccine, but once again, please let people know that because they've received a vaccine doesn't necessarily mean that it's 100% effective in stopping them from getting disease. You know, vaccines are about reducing the likelihood of contracting disease and reducing the likelihood of becoming really unwell or dying from disease. So these are really quite, really safe vaccines. Side effects wise or adverse events, very, very low. Obviously with our 4-valent vaccines, nothing really outside of the usual vaccine safety profiles that we see of other vaccines. So generally localized reactions, maybe a little bit of headache and dizziness, but other than that, very, very well tolerated vaccines. In regards to meningococcal B vaccine, we do know this is quite a reactogenic vaccine, and definitely fever has been noted in children, and particularly the very young children. And consequently from that, there was advice to say that prophylactic paracetamol should be administered prior to each dose of meningococcal B vaccine if children are under 2 years of age. So we would be giving a dose at least 30 minutes prior to vaccination if possible. You are, in general practice, are not expected to run off and get a bottle of Panadol out if a parent hasn't given that prophylactic dose, but just advise the parent that as soon as possible, as soon as they get home, please give the child a dose of Panadol or paracetamol. So if they do have that 30-minute prior to vaccination dose, after vaccination, 2 doses, 6 hours apart, regardless of if fever is present or not. It's really important that these little children don't develop a fever that potentially could lead to a febrile convulsion. Obviously, as with all vaccines, anaphylaxis is exceptionally rare post-vaccination. With the meningococcal vaccines, the rules are exactly the same. If the person has had an anaphylactic reaction following a previous dose of the vaccine, or if they've had an anaphylactic reaction following one of the vaccine components, are the true contraindications. So absolute contraindications. Bear in mind, there are reasons to defer vaccine. So if a child was to present for vaccination, they had a fever of 38.5 degrees or higher, we would defer vaccination until the child was afebrile. And that goes across all age groups. Any person that has a fever 38.5 degrees or higher, we would not be offering them a vaccine today, and we would be asking them to come back. So management of meningococcal disease, it's a notifiable disease across Australia. It does require really prompt diagnosis and treatment, and certainly, as Jenny was explaining, if you have a clinical suspicion at all, please proceed and take those blood tests and start that antibiotic therapy, transfer them to hospital, and they need really rapid clinical management to ensure that this disease does not progress rapidly. So in conclusion, there has been that recent re-emergence of meningococcal W over the past few years. It's a hypervirulent strain, as Jenny was saying. It has a higher fatality rate. Meningococcal disease does claim lives. Around about 1 in 10 people that contract meningococcal disease will die from the disease. Others will have long-term sequelae. Others will recover fully. This disease does progress very, very rapidly. So, you know, we certainly know many experts have used the term well at breakfast, but dead by dinner. So we need to really be super vigilant. We need to encourage parents to really watch children, particularly. They will deteriorate very, very quickly, and to seek medical advice very quickly. We talked about those people who do survive, do have those ongoing long-term health conditions. And it is, you know, a life-changing event for a number of people. We do know that older teenagers particularly have higher rates of carrying meningococcal bacteria, and we do know that we need to get these vaccines into people if we're going to protect people from meningococcal disease. So we have our ACWY vaccines, and we also have our meningococcal B vaccines. And of course, we have funded programs. So definitely ACWY is a funded program in the high school years, and in South Australia, there is a meningococcal B funded program. And I think there's now a couple of other states that have started a funded program for adolescents as well. Any more questions at all?
There is. Looks like Teresa's got a question in there. What was the CFR for Men-Dub and Men-B? Do you think the higher CFR in Men-Dub is due to misdiagnosis as a result of atypical presentation?
Look, good question. Excellent question, in fact. Men-W presentation does actually present a little bit differently. And one of the things that seems to have been noted with emergency presentations is more gastrointestinal upset. So more so than the Men-Bs, but it is certainly a more hypervirulent strain of meningococcal disease as well.
Okay, thank you. And Tanya Stott, can you give ACWY and B vaccines together?
Yes, you certainly can. So not a problem with that at all. People would probably suggest giving them in opposite limbs. Meningococcal B vaccines are really stingy vaccines, so just give them the heads up that it is going to actually hurt them.
Yeah, that's fair enough. Absolutely. Well, looking at the time, I think we can wind up now. Thank you so much to both you, Angela, and of course, Jenny, in the side of the screen there. I can see you peeking around the corner.
Yeah, no,
we're really lucky to have members like you on board to get involved in our events, and the immunisation professionals really love having you talk to them specifically about what they need in their professions. What I do want to tell attendees also is that we have got some amazing opportunities coming up for webinars. We have webinars coming up in influenza in March. We've got pneumococcal disease, which is a big one we have in July. Then pertussis and shingles will come in the second half of the year. We've also got a new podcast that we're launching very soon, which is exciting. We've got a 6-series podcast on the COVID vaccine. So we're going to be talking to GPs and health professionals really about the conversations they're going to be having with their patients in the next few months. Very topical stuff.
Susie, we just getting back to that hematopoietic stem cell question. Yeah. Okay. Yep. It's certainly recommended for them, but it's not on the NIP for them.
Right, great. Thank you.
In the immunisation handbook, there is a table called meningococcal vaccination for people in a special risk group, and it will have a little tiny tick next to them if they are funded vaccines, but hematopoietic stem cell transplant is not a funded vaccine, it hasn't got a tick.
Okay, thank you for clarifying that. That's fantastic. You can always email us at Immunisation Coalition if you'd like Angela or Jenny to answer any more questions after the event tonight. We have got a short survey for you to complete after the event, and we wish you a very good evening and a safe and happy 2021. We look forward to seeing you next time.
Happy COVID vaccinating.
Thanks very
Bye.
much.
Thank you.
Bye.
Cheers. Bye.